Hey there. Welcome to the Pelvis Project podcast. I'm Megan.
And I'm Roxy. We're two pelvic health experts brought together by passion for our careers, entrepreneurship, motherhood, and the desire for intentional relationships.
Join us in our mission to spread pelvic floor awareness and start conversations surrounding the truth behind genuine health, imperfect wellness, and joyfully navigating life. We are so glad you are here with us.
Let's start the conversation. Hello, hello.
Good evening, Roxy.
How's it going?
Pretty good. Let's just dive right in before we get started. Tell me something good.
Oh, gosh, you put me on the spot. Let's see here. I should have known this was coming. We had a fun little weekend. I was been asking all summer to go to the Milford Nature Center. And that sounds so boring.
Oh,
but
fun.
We did it and it was so fun. It was just like a kind of like Saturday morning, let's just go do it. And it was so fun.
That's awesome.
And just like watching them, I don't know. It was just good. So it was like just a fun weekend. I feel like I'm coming off of a fun week, same amount of work and play. I also got some productive things done, which was nice.
Yes.
That doesn't always happen, And so
yes, that's right.
It was just a good balance. But yeah, shout out to Milford Nature Center. If anyone wants a fun little thing, you can go to State Park for $5 a vehicle, do the splash pad.
Fun.
And across the dam is Milford Nature Center, like 5 minutes away. And it's free.
Nice. Nice.
And you get to see the hatchery where they're growing fish.
Oh, that's fun. That's so fun.
Yeah.
Yeah. My Tell Me Something Good is kind of my weekend too. I actually did not have anything planned. And I was looking back and reflecting on the summer so far. And it has been a fun summer, but just, a lot going on, which always it is. And fun stuff, but kind of on the go. And front of the summer's baseball. And we go out of town. And then our church marriage retreat, all these things. And so this was first weekend in a while that we were just home. So my daughter and I laid in bed and watched TV together and found school supplies and then left for a little bit. And I got a massage and she got her eyebrows cleaned up and her face dermaplaned. And it's so sweet because the lady that does this has been seeing me since I was 15 and I'm 41. And so now Grace is about to turn 14 and she's still doing it. And now she's seeing my daughter. So it's so fun to go and do that. So it was a fun weekend. But anyway, okay. Well, tonight we are going to talk about something that we hear a lot of people call about is diastasis recti or diastasis or DR, however you want to call it. And we thought we would just kind of break it down. What is it? Kind of, I don't want to say there's controversy about it at all, but we're learning more and more about DR and, some of the ways that we maybe treat now might change in years to come or even in 6 months because there's more research evolving about this topic all the time. And we know way more about it than when we've used to. I mean, even from I think about when I first started into women's health and, DR at that point, they were like, do not do crunches. Do not do crunches. And now we know that that's not true. Crunches aren't going to make things necessarily worse. So we're going to dive into that and we'll get started. So anything to add, Roxy, before we get going? You want to talk about, why don't you start us off and tell us what is a diastasis recti?
Yeah. Just the word diastasis or diastasis is separation. And so when we put the diastasis and the recti together, it's the separation of the rectus abdominis muscles along the linea alba. And so that's like your six-pack muscle, just for reference there. And so then those two split and separate, and then that can cause dysfunction. What we know is that this is a natural part of pregnancy. We're going to mostly be talking about pregnancy and postpartum women with this, because that's the highest population of people that we really are treating with this. Although before we get started, I will just make a little sidebars. If you have a little kid, a lot of times little kids have this tiny little dome across their midline when they're little. That's very, it's just developmental at that point. But then you see some kinds, even men get it. And you can see if they sit up from leaning back in a lawn chair or something and they have that line down the center of their belly, that's also the same thing we're talking about. And so it's not
Yeah.
just limited to pregnant women, is kind of just, that's all I'll say about that. But it's a natural part of pregnancy. What we know, the research tells us that 100% of pregnant women have some degree of DR in the third trimester. You think about it, like bellies are growing and something's got to give. And
Yeah.
so it's not a dysfunction really at that point. Like it's just part of the natural progression of pregnancy. But it becomes clinically significant though when it goes like it persists postpartum and it's associated then with functional deficits. I think we need to acknowledge that it's happening to 100% of pregnant women. Functionally, during their postpartum recovery, that should come back, migrate
Hmm.
back together. So there's not that big separation anymore. And so when it doesn't do that, then we start to be concerned. And the big like takeaway or the big emphasis that we really are going to chat about and chat through is that diastasis recti is a pressure management and a tension issue more than a gap issue. And when Megan talked about how so much more clinical research is coming out and we know so much more, that's probably one of the biggest stakes that we can say, oh, that's been a big shift. Because when we started,
Hmm.
it was all about the gap and the dome. And we'll talk about this, but it was the split. How big is the split? Like how wide is it? And anymore, we just know a lot more. So we're grateful for that research, but it could be different down the road. We could be saying, oh, yeah, that's partially true, but now we also know this or whatever. And
Yeah.
so we are learning more. It's an evolving topic, but we really want to emphasize that this is a pressure management issue and a tension issue in the abdominals.
Yeah. And so I think that as what we hear a lot is patients or women coming in and they're very concerned about the gap. So like Roxy just said, it's like she mentioned, this is more of like a tension and pressure thing, not necessarily a gap thing. But the common population is still kind of in the head of, well, I have this gap. And so we'll have women come in, and normally as you progress into postpartum, if someone has a DR or the separation, it starts to kind of close at the top and the bottom, almost like zippers coming together at the belly button. So typically right at the umbilicus is where you have like maybe the widest gap or softest, kind of area, depending on where you're at postpartum. But we have a lot of women that come in, that might be 1 or 2 finger widths, and we'll talk about what that means, but they're producing tension underneath our fingers. And that makes us thrilled. So we're less concerned about the gap. We want to make sure that there's tension being produced and proper pressure being distributed versus no fault of us as women. There was a whole episode that I believe I might have been Nicole Cozine had done where she talked about, she interviewed somebody, I think this is a while back, and how, you have to meet the person in the room, because if who's coming in the room is really hung up on the gap and it like cosmetically too, and we're like, oh, we don't need to worry about that because you're producing tension. It's just something that it's like, okay, like, we're telling you this because we just want you to not be afraid of it. We don't want you to be afraid of exercise. We're going to load the tissue. We'll talk more about that. And there's a lot of healing that can take place. But there's still kind of this mindset a little bit of, well, I have a DR, so therefore I'm weak, or I'm not strong enough, or I'm going to hurt myself. And we're just here to tell you that's not always the case. Just like, Roxy mentioned, this becomes an issue when there's like functional deficits. So if you're, working out, you're doing well, but you're not having any, sort of issue, then, maybe you're just checking in to make sure that everything's, properly activating, but you're doing great. So I think that that's just one thing that we definitely see a lot of is encouraging women. And we'll talk more about kind of some experiences we've had in the clinic. And, I know that I have challenged some of my postpartum mamas in that sort of space of they're being fearful of having a little bit separation left and being able to show them what they can do and, gasp, take them through like a full range big setup. And guess what? They have no sinking, they have no doming, they're able to control, and they're like so excited that they can even do that. So, okay, let's move on to risk factors and myths. And so even when we talk about common risk factors, again, this isn't an all or nothing thing. So, for example, multiple pregnancies could be a common risk factor, but that doesn't mean that it is for everybody. So, when we say these, you have to kind of think like, okay, so again, maybe having a larger baby could be a risk factor. Well, for somebody who has a large baby, they could do just fine. That's where this stuff becomes kind of like it can be and it can't be. Potentially, maybe maternal age, potentially cesarean deliveries, connective tissue disorders. If there's a lot of straining that has happened, like with chronic constipation, that sort of thing, improper core loading, those are all just factors that we want to consider when we're talking about this topic. So, a couple myths. So, myth one is crunches cause a diastasis recti. That's not true. So typically the truth with that is the crunch isn't what's causing it. It potentially is poorly managed inner abdominal pressure, and that's what can contribute, not the movement itself. So to strengthen, we need to take those muscles through the full range. But if we have weakened tissue and maybe we're holding our breath and there's some different factors in play, that could be more of what is making the exercise not ideal. And so if we can correct that, then the crunches are actually just fine. And then one other myth we'll bring up is that surgery is the only way to fix it. And again, most DRs respond well to conservative rehab, especially when tension and function is improved. So as long as we're starting to get that tension built back up, we're getting stronger, we're loading, which we'll talk about what that means later in the episode. As long as that's going well, people do really great.
Yeah, I just think that some of these, like, I think this little chunk of information is where people get in trouble, and it can be really fear mongering of like, you read some kind of blog or something and some lady like maybe had to have surgery. So then that's like the assumption that everyone has to have surgery, or maybe vice versa. Like you see of like sometimes fitness trainers are like, do these two moves and you'll fix your diet, like you'll fix your DR postpartum, or if you want to prevent it, Well, we just heard that 100% of pregnant women have it. And then there are some risk factors. So I think we have to really be careful that like always, never, those types of verbiage.
Yes.
That can just like generalize in a really unhealthy way. And so it's easy to see why there's fear around it, because a lot of people have taken their personal experience and made it like a protocol or made it like a example of some sort to guide others through that just based off personal experience or whatever, their own journey. But there's just a lot more that goes into it than just having a big baby, like Megan said. Usually there's layers of like complexity that have like brought that to where it's at. So let's chat then. Let's kind of segue into how do we assess this, or what are we looking at as clinicians when someone comes into the clinic, or like maybe you're thinking, how do you even know if you have one, right? What we know and what's true and valid is that, Megan talked about this gap. So imagine a 6-pack, right? And in between that, there's that line, there's a gap. Or there's a line that's there's like a little divider line in between. There we go. We're looking at the gap. We're looking at the space in between there, but we're also not worried about that as much as we used to be, right? And so it's more than just how wide apart those two strips of abdominals are at this point. What we look for is the tension. And so that means when you contract, what tension is generated there? We're looking at the depth. And so when we are palpating that little space in between those two muscles, how deep does that end feel? When do we hit something versus just skin? So the tension, the depth, and then the pressure control matter the most. And so from a clinical assessment, usually we have people laying on their back. They can do a little head lift. And while they're lifting their head, our fingers are strategically placed at different places along that line. We can feel like, let's say we put 2 fingers in that line and then we have someone do that little head lift. If we feel that pinch tight on both sides of our fingers, and we know that's a 2-finger width gap, if that makes sense. But what we're also feeling is that depth. Where do the tips of our fingers, not just the sides of our fingers, but where do the tips of our fingers go? And we do that along the line. So we can, like Megan said, there's kind of sometimes that zipper presentation where it's narrowest at the top and the bottom, like above and below the belly button, but then right at that level of the belly button, it's widest. So we're kind of going along that line so we can really get a good idea of where at it's widest, or maybe where at it's most compromised, or the depth along that too. Which one is there more tension generated closer, like higher up or lower down? You can also use ultrasound to do this. That gives us just that real time feedback on like muscle recruitment. And we can see that on a screen then is how well is the muscle recruiting and what's that looking like. Some people have like ultrasound imaging in their clinics and some of us don't. So we
Yeah,
use the good old fingers.
Yes, yes.
That's our feedback there. So some red flags in that we're looking for. So that's how we assess it is we use our hand or we use an image, but we're looking for like bulging and doming. And that doming is just where that when they lift their head, you can see that midline displace high. It kind of pushes up and there's a little mountain range basically that happens along there. And we call that a bulge or a dome usually. Most of these people have back pain because their abdominals are compromised. We talked about that function earlier. And so we start to see that function lacking. They're going to have back pain. A lot of times then there's also pelvic floor symptoms, leakage, heaviness. And a lot of times that also is a factor of that pressure management too. If we really think about what's happening there, then that is, and we'll talk about that here in a little bit, but if we're pressurizing the abdominal canister, then we're going to see that dome at the midline, but that's also going to push down on the pelvic floor and we're going to end up with dysfunction there too. And then difficulty with core engagement. A lot of times we're seeing these people have their abdominals just are not coordinating very well as a team. They might have a hard time like connecting with those muscles. And we just notice we're watching for that as well as feeling for that. And so a red flag then is if we're seeing that lack of coordination or that lack of recruitment happening.
And remember, when we're talking about this population, we're talking about postpartum. So when you're listening, everything that Roxy just said, you're keeping in mind the like newly postpartum mom that's coming in, that their abdominal wall was just stretched to the max. And so a lot of times when somebody first comes in, I can't tell you how many times we'll start, like going through some of this and they're like, oh my gosh, I can't find my core. I don't know how to kick it on. And I'm like, it's okay. No worries. Like, we'll like go through a few things. I'm like, by the time you come back here in 2 weeks, you will have found it again. Because it's just a little bit that it takes some time. And so just like the all or nothing statements we're staying away from, you very much could have a DR and not have back pain, not have pelvic floor symptoms, not have these things. It can be a standalone. I mean, it can. So just keeping that in mind, that's where this is. It's just, there's a lot of different like nuances with it. And so that's why, I mean, Roxy and I, for sure, like we're treating who comes into the room here. And we're going to be assessing based off who's walking in and all the factors that go along with that. Is this a mom that is a first-time mom that doesn't have a lot of support at home? Has a baby that's colicky and crying all night? Is she worn out? Like all these things. Does she have autoimmune disease? All this. Or, is she a mom who worked out consistently, was like a CrossFitter, worked out consistently through pregnancy and comes in and is like bouncing right back. So again, you just have to keep this all in mind when you're thinking about these patients and treating them. But what we do know is with this, we want to improve strengthening. And so we'll talk a little bit here now about like kind of like treatment and recovery. But I think that this is a good place to kind of mention too. And Roxy and I kind of had a side conversation about this. And I know we feel mutually about it, but this is where having an assessment done by somebody who is, certified and does this work with pelvic floor, even if you go in for one assessment to see how everything is coordinating together, if you're going to, let's say, an exercise class that's like, let's restore your core and pelvic floor or core rehab, but you haven't had an assessment done yet, and you're having some of these symptoms, we would hope that whoever it is that you're working out with would say, hey, why don't you go get an assessment? It doesn't mean you can't go work out with them, but you need that assessment to be able to tell you exactly kind of what's happening and almost like how to coordinate it better. So I hope that makes sense. Anyway, let's talk about treatment and recovery. So principles for management. So let's just talk about like in the beginning. So first, we need to kind of like restore optimal pressure systems. So again, this is the postpartum mom. So thinking about, we're looking at like diaphragm core, pelvic floor coordination, all of that, and then retraining kind of more the deeper layers of the core. So TA activation, that's transverse abdominis, breath mechanics, posture. And so through that time, we're really like avoiding over cueing and over bracing. So this is functional control over rigidity. So we see that a lot, kind of the over bracing. I just had somebody today where, again, it's always surprising. It's people you think don't have any issues with activating their core and pelvic floor. And then you lay down and we're trained to, we watch for things. I'm looking at when somebody takes a breath and then they show me this activation. Are they gripping down with their ribs? Because if they are, then we're having a pressure shift come down. What's the rib cage doing? Is it moving? Like, is it mobile? It's just there's multiple things we're looking at. And I don't know that people really kind of realize everything that we're actually assessing when we're looking at somebody activating. Okay, so exercise progression. So in those early postpartum days, again, depending on what your level is. So I've had people come in that, man, they worked out and did core activation work their entire pregnancy. They found it right away. And we just continue, we just come, right? It's like we never skipped a beat. But this is like kind of like, just like standard, coming back in and needing to refine everything. So early postpartum, we're going to do a little bit of breath work. We're going to just be able to find those muscles again, activate. I don't really spend too much time on pelvic tilts and that sort of thing. I just kind of, I don't know, Roxy, if you do that stuff anymore, but we we don't really need to do that. So, I think there's a lot of programs out there that's incorporated in there, and that's fine. Again, it's not an all or nothing. If that feels good for you, you can. But in the beginning, we're first just assessing, and if you can activate and provide tension, and we are seeing that and you're maintaining, but we're going to go ahead and start progression of, core. And that could be, it could be as basic as a bridge, or it could be progressed into, dead bugs. But some of the new research that just came out has talked about how, yes, isometrics are really important. And I use those. I know Roxy uses those. But their new research is also showing that it's important that we also do these strengthening core exercises where we're approximating the rectus abdominis. And that means something like crunches. And so, again, that's something that we're working towards, and we need to overload. So we kind of work through, it might be that you do planks or bird dogs or, that sort of thing, and you progress and you start to load. And so then we have this advanced loaded movements that we are making sure that we're still able to maintain good pressure management, good control, and get you on your way back to feeling, like you don't even have to think about it, which is what we really want. So this core focused rehab improves function and reduces that inner recti distance over time. We know that that's what the research shows, is that we need to overload. So, for example, like I mentioned before, I had a mom come in who was fairly postpartum, and she had a little bit of a DR, but she could, every time she would activate, she had such good tension underneath that gap. And so I wasn't concerned. And so I took her through, fully laying down supine, hands up to 90 to the ceiling, use like kind of like a ball, or you could use like a Pilates ring. And she did a full, sat herself up, did a whole spine roll up. And I just watched her core, and she did fantastic. And so I think that really we don't need to be afraid of exercise. It's just sometimes it's like, okay, well, maybe I make a modification if I need to for a couple weeks and I get stronger, and then I can do without. Roxy, any other thoughts with that?
Yeah, just as you were talking, I was thinking about, if you just showed up at a gym to work with a trainer, and you said, well, how are you going to help me? It's like everyone's going to go in at a different entry point. Like some people, like what they start some people with isn't going to be what they start the next
Yeah.
person with. And
Yeah.
that's kind of what Megan, I think, was trying to say, of just like, yeah, you could have like kind of, I guess maybe some people have like a protocol, but shoot, like if someone can't engage their core, then we're going to start there. If they can't even connect, sometimes postpartum, our body doesn't know up from down. So if they can't even connect with that and they can't engage it correctly, then we're not going to progress them until they have that like skill or that connection made. And so just even trying, I mean, not that we can't explain what the treatment is, but it's typically a progression where, like Megan said, we are looking at specific things and we're not just looking at them isolated. But I think the other piece that some people maybe don't realize is how much like finesse has to happen and how much
Mm-hmm.
coordination between different parts of our body and like our butt cheek squeezing when we're trying to engage
Mm-hmm.
our core, or just like that's just an example. But I think that just considering that there's a lot of layers, there's a lot of coordination. The pelvis and the abdomen they are the junction between our upper half and our lower half. So we have to then progress through lots of different types of movements and really be analyzing how are those abdominal muscles engaging and are they promoting function? Are they promoting stability? Or is there a wide gap or a deep gap or pressure struggles there that are then fueling dysfunction or fueling compensation that leads to either dysfunction in the moment or like down the road? And so it just is it's a hard kind of concept to explain because we are actually, like Megan said, we're looking at the person in the room, and that is 100% fact. Like, we
Yeah.
have to just look at the person in front of us, use our rational mind. There's not really a protocol to go
Right.
exactly this fast, this way, this exercise first, then the next exercise. There's been some people that can actually do maybe like one certain type of movement that's maybe a little more complex, but then you put them in a different position and they really struggle with that. And so it's just not like a linear progression or like a one size fits all when it comes to like, what does this actually look like?
Yeah. And I mean, okay, here we are. Let's talk about the mom that comes in that does have a connective tissue kind of disorder, is maybe very petite, had a large baby, and now has a four-finger width DR that isn't producing tension underneath, that very much has, I mean, pretty significant and severe separation. There are those women that come in and they do have to have surgery. And so I think it's just like keeping in mind that we're treating who is in front of us, and also taking away from this conversation is that we don't need to be afraid of exercises. Even if we have an ab separation, we don't have to be afraid of it. I have people all the time say, well, do you think it would be okay if I tried XYZ? I'm like, yeah, let's do it. Like, we won't know until we try. Let's give it a go. And I think that honestly wasn't how I used to treat. And so, and I can say that. And I love those conversations of like, again, I know Nicole has posted before and been like, what's something you used to think or believe that you don't now as a therapist? And I think that's what's so great about our field is we have some really great like trailblazers that are out there continuing to share like what's the latest research with it. And we just can't emphasize enough that that's why sometimes in the beginning group activities or group fitness is tough, because it is kind of just this one size fits all and we don't really have eyes to see what is happening. And it is really fascinating. Roxy and I both did the Sarah Duvall pregnancy and postpartum corrective exercise course. And oh man, that was a robust course and so much good information. But that's where like some of those little slight instances that we are looking for is kind of, that's the course that I know for me, Roxy, I don't know about you, where I started to pick up on a more of like, oh, because Sarah's amazing at being able to watch somebody do an exercise and be able to show you like, do you see this? Do you see that? And do you see how the rib cage came down there and how the pressure there and the way the foot went? And so it does, there's lots that goes into it. And I hope we're getting also the point across. It's more than just Kegels. So if anybody's also still thinking that, please stop. Please stop.
Oh,
So, all right. Well,
seriously.
let's talk
Well,
about realistic expectations.
yeah. So we just want to maybe end on an encouraging note here and just to normalize the slow and steady sometimes wins the race in our world. Like, it can take months or more to restore this tension, and that's not to be discouraging, but just to give you some realistic expectations that it isn't like the bounce back culture doesn't support function as
Yeah,
much as maybe just like
absolutely.
aesthetics. And so some of the best things in life come with a little bit of patience and time and diligence and hard work. And And that's maybe where we really want to set the tone with when we're talking about these abdominal split. Takes 9 months for our belly to get to its fullest, right? And then it's not just going to shrink back with zero dysfunction. Sometimes it might, right? Those are the lucky ones, but
Yeah.
sometimes we have to help it along and we have to encourage it and train it in the direction we want it to go. So closing the gap, and so really thinking about that width, closing the gap is less important actually than just controlling that gap. And so I think we can let go of any type of assumption that tells us that our gap is too wide or that that's causing all of our problems or whatever. Rather, how's our body managing that and how is it functioning day to day with the circumstances and the positioning and all the, all those circles of influence that are around it as we're just walking through our day and moving through our day. And finally, then you can be strong and you can be functional, even if that gap remains. That's really what our aim is with our patients. Our aim isn't necessarily to have this objective decrease in numerical measurement between those two abdominal
it's great.
pieces.
It's great if it does.
It's great if it
that's
does.
what we want. But
we're looking more at function. We're looking more at how can we get your body to heal well and to be resilient no matter what activities you want to be doing. And that's where we're going to go for function and quality of life more than just this really rigid and objective number that maybe, to be in all honesty, some people have no DR yet their core isn't supporting them well and they still have back pain, right?
It's so true.
So it's just, there's not these like really objective A plus B equals C all the time. Anyway, we just want to leave you with that encouragement that there's so much we can do. This is in the realm of pelvic health, even though some people are like, do you do this? I know it's a little different. Like, absolutely. It's part of the canister. Like, this is our bread and butter. We're doing this a lot, actually. We are the experts on this, and we're the place that you need to go if you're struggling with that dysfunction. So, but we see people get better all the time and thrive, and moms be able to be the best version of theirself. And that's so fun to see.
Yep. And I will just say, my last 2 cents, 2 things. One, if you are postpartum, I would highly recommend a pelvic floor assessment at some point after you've had your baby. And that does not mean that if you come and see us, we're going to keep you from going and doing fitness classes or whatever. We are here to cheer you on and just make sure that we're giving you proper feedback that maybe you aren't getting at that 6-week postpartum check, because what they're looking at the 6-week postpartum check is different than what we are looking at that 6 weeks postpartum check. And so I know it's going away from DR and to more just postpartum recovery here, but there is no way at 6 weeks when they're like, good, you're cleared to go back. It's like, I'll have to come up with an analogy for that one. And we have all been there. Roxy's been there. I have been there. And in fact, I had my babies before I was even in pelvic health. So I was in the dark too. I was just like, okay, whatever. And I just kind of went back. So I'd highly recommend. It is powerful. It can set you on the right trajectory so that you can just know, have that base information. If something comes up, let's say you're not leaking and you go back to exercise and suddenly you are leaking, you have some knowledge of maybe like, oh, okay, or we have a baseline. So there's that. And my second thing I was going to say is just to any mom that's listening out there, and maybe you're postpartum, keep doing the hard things, keep showing up for yourself. We know it's hard. We know that sometimes, you're sleep deprived and you're touched out and you have everybody else's needs, but it's worth it and you're doing great. And that just comes from a place of like, I've just had some moms here recently that I've been with through multiple pregnancies, and they're coming in and they're just showing up, and I'm so dang proud of them. So that is all I will say. And Roxy, you're one of them. So, oh man. All right. Well, we hope that this episode was helpful and a little insightful on diastasis recti. And if you have any questions, please send us a DM on our Instagram handle. And as always, we will keep the conversation going. Thank you so much for joining us this week on the Pelvis Project podcast. Help us continue the conversation by liking and sharing this episode with friends. And if you really want to do us a solid, leave us a review. If you'd like to follow us on social, check out the show notes for links. And remember, this week, take a deep breath and relax your pelvic floor.